Thank you very much for giving me the opportunity to talk today. No conflict of interest. All the presentations up to now have shown that the impact of stigma and of acromegaly doesn't just stop at treatment, whether that is surgical treatment, radiotherapy, or medical treatment. The patients who have acromegaly will carry on living with the impact of the condition for life. So this is a photograph which Professor Ashley Grossman actually gave to me. This is Marianne Bevan, and she was voted the world's ugliest woman alive, so about 150 years ago. So just again to emphasize how difficult it must be for these patients to live with a condition, not only inside, but also their appearance, and everybody can look at them. They feel like people look at them constantly. So what I would like to talk about is the aftermath of surgery for patients who develop hypopituitarism and how you replace the hormone deficiencies. Not very common in acromegaly, but it's still quite important, especially for patients who have had surgery and radiotherapy. It's really important to look for hypopituitarism. So I will start with a case study, a very brief case study. Mr. M, he was 50 years old at diagnosis, and looking back, he reports a history of 4 or 5 years of acromegaly-related symptoms. He said, I was invited to go on holiday with a friend who I hadn't seen for about 6-7 years, and this friend happened to be an orthodontist. And his friends said to him, "Mate, I hate to break it to you, but you've got acromegaly." So here is this man going on this lovely holiday to find out that he has acromegaly. So a month later, he had surgery, which was followed by radiotherapy a year later. He was diagnosed with LH, FSH, and testosterone deficiency in 2006 and started testosterone. TSH deficiency was diagnosed 2 years later, and he started thyroxine. So a 9 a.m. cortisol was ambiguous. For this, he had an insulin tolerance test, which showed a peak cortisol of 360 nanomoles per liter. We would expect in the insulin tolerance test the cortisol to go above 500 or 550 nanomoles per liter. And for this, he started hydrocortisone twice daily, and that's mainly preference because he couldn't remember to take it 3 times a day. And he also had a peak growth hormone of 1.3 micrograms per liter. Again, the normal range, the peak response you would expect in this test is 3 micrograms per liter. He started feeling very tired the following years, and we used the AGDA assessment of growth hormone deficiency in adults, quality of life questionnaire. And in 2010, he had a score of 17 out of 25. So anything above 11 indicates an impaired quality of life. So I'm not going to go into investigations how to diagnose hypopituitarism, but I mainly want to just remind you very briefly the anatomy of the pituitary and the hypothalamus. So you've got the posterior pituitary and diabetes insipidus resulting from deficiency, the anterior pituitary controlling most of the endocrine glands in the body, so thyroid, adrenal, gonads, the entire body from growth hormone, and prolactin, which is not relevant here. So how we replace those hormones? ACTH with cortisol, mainly tablets. TSH with thyroxine, free T4, and sometimes free T3. Again, that's a whole different story, so I won't go into that. Growth hormone with somatropin injections, and FSH and LH testosterone in men, estrogen, progesterone in women, and vasopressin with DDAVP and desmopressin. Prolactin, as I said, hyperprolactinemia can be a problem, but deficiency, there is no need to replace. So what's the treatment objective in hypopituitarism? Optimal replacement and benefit in quality of life, but at the same time we want to make sure that these patients are not under or over replaced, because under replacement they won't have the full benefit of the treatment. Over replacement, they will have side effects. So if we start with the cortisol, again, I know Catherine will talk a little bit more about the cortisol, so I won't dwell into that very much. The recommended regime for cortisol replacement is starting with 15 to 20 milligrams hydrocortisone in 24 hours, ideally administered in 3 doses because of the short half-life of the hydrocortisone. And generally people will have half or most of the dose on waking, and then the rest of it divided in 2 other doses, lunchtime and evening. So if the stress test shows that the ACTH, the cortisol on ACTH stimulation is borderline, then consider 10 milligrams only, or a much lower dose, and that can be once a day or divided in 2 doses a day, 5 milligrams. The general, I say to my patients is, because they ask exactly what time I should take the hydrocortisone, well, there isn't really an agreed regime, but it's best to be taken on waking, and the last dose shouldn't be taken too close to the sleep time. A lot of the patients will have different lifestyles, different times they wake up or sleep, so you can't really say at 6 in the morning. There are other options available for hydrocortisone, and we have the Plenodren, which is the modified release hydrocortisone, and that's taken once a day, 20 milligrams. Prednisolone once or twice a day. And dexamethasone, I don't think it's used anymore, but we still see some patients who can be on dexamethasone. We all know the problem, the difficulties with the traditional hydrocortisone replacement therapy. So this is the diurnal rhythm for a normal cortisol production. So you get the peak level of cortisol before waking up, so first thing in the morning, and it drops quite low midnight. So this is what you get with hydrocortisone replacement. So you get the very peaks, and then obviously more peaks through the day. So the elevated evening levels are associated with alterations in glucose tolerance and insulin sensitivity, coronary artery calcifications, and insomnia, as I mentioned earlier. Thyroxine, so replacement for TSH deficiency, so that's free T4, and it's levothyroxine tablets. The average dose for the adults is 75 to 150 micrograms taken once daily, ideally, again, on waking, on an empty stomach. And we aim for mid to upper end of normal range levels of free T4. And always remember that the dose may need adjusting when patient starts on growth hormone. So I wanted to have a couple of examples throughout my presentation, just mainly to ask you your opinion. So here is our first patient. He's been having very variable free T4 levels, even though the dose of thyroxine hasn't changed. So he's on levothyroxine 100 micrograms daily, and he has been on that for the past 2 years. There is no doubt about adherence and compliance to treatment. He is taking his tablets every day. so he was taking at the same time, sometimes, not every day, calcium and vitamin D and other minerals like zinc, iron, and multivitamins. So, and because he was taking it on and off with the thyroxine, we used to get these up and down levels of thyroxine. So again, use your nurse's brain when you think about these situations rather than follow numbers. Similarly, we get a lot of patients who call in because the GP will lower the dose of thyroxine because of low TSH. So remember to advise the patients that TSH and the doctors that TSH cannot be interpreted in hypopituitarism because it's always low. So we go by 3T4. LH and FSH deficiency in females, that's oral estrogen and progesterone, and they can have regular withdrawal menses or continuous, in which case they get no withdrawal bleeds. Transdermal estrogen and progesterone is an alternative, and it's preferable if they are on growth hormone treatment. So again, as I said, especially the ethinyl estradiol interacts with the growth hormone, so you need to bear in mind if there are any changes. Testosterone deficiency, LH-FSH, testosterone deficiency in men, we have a lot of testosterone replacement therapy options. The intramuscular testosterone ester, so that's the sustanon or enantate, and that's every 2 to 3 weeks intramuscularly. The testosterone andecanoate, the Nebido, every 3 months generally. And we were just talking about it with Chris that is not available in the USA because it hasn't had FDA approval because of the risk of pulmonary embolism. It's pretty safe. I have only seen one patient who had a reaction to it, but otherwise, if it's controlled and monitored properly, it's safe. A transdermal gel or patch once a day, and the Bacal tablet once or twice a day. So the safety issues we need to consider with the testosterone replacement therapy is polycythemia, and we tend to see this a lot more with the injectables. And that's mainly because of monitoring. So if the patient's testosterone andecanoate, for example, doesn't get used, I don't know if that's the right term to use, and they have another injection very frequently, so close to each other, then they tend to get build-up of the testosterone levels, which results in polycythemia. If you space out the injections to the individual's needs, you tend to see less. PSA should also be checked every 6 to 12 months. Got another patient here. So he had very high levels of testosterone. Our lab will only report up to 52, so they reported testosterone level above 52. He's on a small dose of transdermal gel, so the Testogel half a sachet, which we lower as a result of the high testosterone, and he still carries on to, we still carry on to see very high levels of testosterone. What's that?
Contaminated sample?
Yes. So he was applying the gel onto his arms area. So we were actually reading the testosterone on the skin in the blood sample. I normally will say to my patients, make sure you apply the gel and have the blood test within 16 hours at least, because if it is more than 24 hours, the testosterone will be low because of the half-life. Similarly, avoid the arms area where the blood test is taken. For the injections, again, we need to interpret it depending on when they had the injection. So if it is a testosterone ester, 3 weeks later might be quite low, a week later will be high. And that's a few options here for testosterone. So this is not actually available in the UK, the buccal tablets, but I think it is available in the rest of Europe. So if the patient requires fertility treatment, we need to replace directly LH and FSH because testosterone, estrogen, progesterone doesn't restore fertility. Generally in men is done with HCG and LH FSH injections 2 to 3 times a week, and for women with ovulation induction. Diabetes insipidus, very rare complication of post-acromegaly surgery and radiotherapy, but we still see it. So the treatment for that is a nasal spray or oral tablets or the sublingual tablets. And the frequency and the dose really depends on the patient needs, and we also check plasma osmolality and sodium levels. But it's mainly symptom dependent, and patients pretty much know whether they need to take less or more. We suggest to the patients to omit the occasional dose of DDAVP once a week, and that's because they want to control the symptoms. They tend to have fluid retention. So give their body the chance to excrete any extra fluids. And as I said, the DDAVP requirements may vary from season to season as well. Growth hormone, a little bit ironic when the patient's condition is caused because of growth hormone supraphysiological levels, and then post-surgery, post-radiotherapy, they actually need to have growth hormone replacement to maintain their quality of life. But we do have a number of patients who are on growth hormone replacement post-acromegaly, cured patients, and they potentially develop growth hormone deficiency. As you know, the symptoms for growth hormone deficiency: increased fat mass, decreased lean body mass, bone density, decreased cardiac function, increased atherogenicis, impaired glucose tolerance, impaired thermoregulation. So quite a range of symptoms. We generally tend to treat patients in the UK because of impaired quality of life. And we do find that if patients have more than 2 deficiencies, they are very likely to become growth hormone deficient. Again, you can see here briefly how increased lipolysis, improved lipid profile post-growth hormone treatment. And I mentioned earlier the ACDA quality of life questionnaire. It has 5 different aspects, and you can see here post-treatment with growth hormone, the aspect that actually improves most is the energy levels and memory and concentrations. So problems with socializing, tenseness, self-confidence. Similarly, years of treatment with growth hormone, so it continues, quality of life continues to improve up to 8 years post-treatment. We generally start with a low dose, 0.2 to 0.3 milligrams a day, and titrate based on IGF-1 levels. And we monitor, we aim for mid-normal range of IGF-1 and monitor every 6 to 12 months. Another example. So this 28-year-old patient who I've known for a number of years, she's on levothyroxine, combined oral contraceptive pill, and growth hormone treatment. Her IGF-1 has been stable for a number of years, and she's on the same dose of growth hormone. So she calls me and says, I have terrible fluid retention, muscle and joint aches, and headaches. What could it be? Any ideas? I'll give you a clue. She wants to get pregnant. She stopped the pill. So as I said earlier, ethinyl estradiol, when patients are on ethinyl estradiol, they require a much larger amount of growth hormone to keep the IGF-1. So she stopped the pill, IGF-1 jumped up. She gets all the side effects because of growth hormone over replacement. Again, just remember, growth hormone interacts with sex steroids, thyroid, thyroxine, and glucocorticoids. This is, it looks a little bit complicated, but it's one of the algorithms I use when I advise patients on starting growth hormone, because we have a lot of options for growth hormone devices, and patients can get very overwhelmed when they come to start the treatment. So if they are needle phobic, there is a needle-free one, no access to the fridge, a medication, an option that can be kept out of the fridge for up to 6 months for this one, and 3 weeks for this one. Straightforward pen devices, pre-filled ones, which are quite good for patients with impaired vision sometimes, and when we have compliance issues or cognitive issues, dexterity problems, that's a good option. And as I said, I would like to thank Professor Ashley Grossman for giving me some of his illustrations and slides. Thank you.